A very good afternoon, everyone. Before we begin today's session, we should all know that abnormal arrhythmias account for 15 to 20% of deaths every year, and atrial fibrillation alone raises stroke risk by 5 times. So every year, we celebrate World Heart Rhythm Week from 17th to 13th of June, where the mutual purpose of the drive is to increase knowledge on heart arrhythmia among the general public as well as medical professionals to promote the management of arrhythmias. So elevated heart rate is an independent risk factor for mortality and morbidity in healthy individuals with or without hypertension, and also in patients with coronary artery disease, myocardial infarction, and congestive heart failure. It is thus crucial to understand the close connection and impact of heart rate on the different stages of cardiovascular disease and how pre-emptively targeting it may prevent future cardiovascular events. So today's MasterSeries talk coincides with the World Heart Rhythm Day. So welcome to this brand new session on the role of heart rate in cardiovascular diseases. We have with us Dr. Sunil Sathe here. Welcome, sir. Dr. Sathe is a consultant cardiologist, cardiac care and counseling center at Sahyadri Hospitals. He has been listed as a noteworthy cardiologist by Marquis Who's Who. He received a Har Gobind Foundation Scholar Award in India in 1991 and has been a consultant cardiologist at Pune Research Center in Pune and also a chief electrophysiologist at Ruby Hall Clinic since 1994. It is so great to have you with us here, sir. Requesting you to please begin your talk and starting with a message for our World Heart Rhythm Week.
Good afternoon to all viewers. At the outset, I must thank Doc Plexus. This is a good forum where, we can share our thoughts and views. So today I'll be talking on heart rate in cardiovascular diseases. A very simple talk, but extremely useful in day-to-day clinical practice. If you see the first line, it's interesting. This was 100 years ago, Joseph Campbell. The goal of life is to make your heartbeat match with the beat of the universe, to match mother with your nature with mother. So in fact, somebody was thinking about your heartbeat and heart rate almost 100 years ago. He was a great philosopher actually and a scientist. And that time he thought that, you have to match this was basically with nature. And that's why the whole idea was that your rhythm of life should match with the rhythm of nature. And that was the idea. This was 100 years ago, remember. Now, if you see longevity, overall, lesser the temperature of the body, lesser the respiratory rate, and lesser the heart rate, you are going to live longer. Remember this. And that is why, different animals have a different lifespan. And this is an interesting mythological equation which people don't believe, but I must show it because it is mentioned 2000 years ago, that everybody is born with a fixed number, which is heart rate into respiratory rate. Everybody's number is different. So if your heart rate is low, your respiratory is low, you will live longer. So this is a mythological equation. And in fact, this was interestingly mentioned in German American College of Cardiology many decades ago. That means that is the importance of heart rate in our day-to-day lives. And this is what I want to show you. See the tortoise, respiratory rate of 5 per minute, heart rate of 7 to 10 per minute, and the dog who lives for 100, 400 years. And the dog, respiratory rate of almost 30 to 40, heart rate of almost very high heart rates. The lifespan is only 10 to 14 years. And similarly, in different people, depending upon your level of activity. Now, if you see heart rate, remember it's the sinus node. You all know this. I'm just showing you a basic slide. Then in the sinus node, there are 4 channels: calcium T, calcium L, potassium, and IF, small f, it should be small f. IF, which is dominated by the HCN gene. Now, this actually decides your heart rate. And the phase 4 of sinus node is called hyperpolarization. That means it comes earlier than all other tissues. And that is why sinus node is the initiator of your pulse or your heart rate. This is just the basic thing you must know. And physiologically, gender, age, all matters. For example, females have a slightly higher rate than males. And as you age, you can slow down. So there are physiological factors, diurnal factors. But basically now what we want to look at in cardiovascular diseases is that in different diseases, heart rate in cardiovascular diseases, what is the overall mortality depending on the heart rate? We are going to discuss atherosclerosis, stable angina, and different clinical patterns which you see in our day-to-day clinical practice. Starting with the first and the most important, that higher the heart rate, remember, pulse rate, higher the sinus pulse rate, higher the mortality. And we'll see in a stress test what it is supposed to be. And these are the figures which clearly show that if your heart rate is from the CAS registry, see your heart rate more than 83, see your mortality. See what happens. That your survival curves go down. Your rate is less, about 60, survival rate is better. Similarly, adjusted survival curves for cardiovascular mortality. So higher the heart rate, overall mortality is higher, number one. Number two, this was an interesting study where they followed up almost thousands of patients in Sweden for 21 years. And they actually examined them 3 times in 21 years. Okay. And they looked at their heart rate, ECG, and lab analysis. And they found that higher the resting heart rate was associated with higher cardiovascular events, number one. Number two, this was worse when you are between 50 and 60 years, had the worst outcomes. And more important, if compared to baseline, say 10 years ago, if my heart rate is 65, after 10 years later, my heart rate is 75 or 85, that prognosis was worse. So as you aged also, if your heart rate increased, that was not good. Okay. So this was for general mortality. Now, this is an interesting paper in NEJM many years ago. So many of you do stress tests. Your stress tests are say negative, nothing to do with ischemia. What do you look at a stress test as far as the heart rate profile is concerned? In a normal person, no ischemia. So you have to look at 4 points. Number one, resting heart rate more than 75. Lower maximum heart rate means you start an exercise, your heart rate reaches only 140, but it reaches very rapidly. First stage, suddenly you are at 130. And during recovery, there is sluggish response. That means the heart rate drops less than 25 per minute, very slowly. If you have this in a normal person, then your heart rate profile is adverse and you are likely to have more cardiovascular events. So very simple parameter on a simple stress test, which you must know. Now, what does increased heart rate cause as far as atherosclerosis and vascular stress? That means stress on your arteries. Higher shear stress, more vascular fatigue, more endothelial dysfunction in the coronaries, and more artery. That means your arteries become rigid. So basically, the arteries become rigid. So these are the 4 important points as far as heart rate on shear stress is concerned. Now, higher the heart rate, more the progression of atherosclerosis and higher incidence of plaque rupture. Okay, and that is why you will see that young people, especially young people who are hypertensive, who go to the gym, who are dehydrated, and who have a very fast heart rate are prone to have plaque ruptures. Those are important 4 parameters. And this is some data which clearly shows that higher the heart rate, more the atherosclerosis as far as the angio is concerned. And this is a recent evidence which showed that if you have a higher heart rate, see, they actually compared, it's an interesting study, compared heart rate with calcium scores, which is one of the risk factors for coronary artery disease. And they showed that if your heart rate is more than 85 or more than 80, your calcium score is likely to be higher than 400 in a significant number of patients. So that is the importance comparison of atherosclerosis and heart rate when they compared calcium scores on CT scans and heart rate. Now, coming to the clinical structure of stable angina, we all know most ischemic episodes are triggered by increased heart rate. Resting heart rate is a major determinant of myocardial ischemia. And now, heart rate more than, when I say higher heart rate means in most of the studies, more than 83 or 85, and in some studies, more than 90 at rest is the risk factor. Okay. And in fact, there are several scores several years ago, which determine for stable angina, which have kept heart rate more than 85 as an independent risk marker for coronary artery disease and events. The second important point you must know about stable angina and heart rate is that why do we give beta? What about when we give beta blockers in stable angina? What must we look at? You must look at two things: that the resting heart rate should not exceed 80 per minute, and number two, when the patient has a positive stress test, you must look at what pulse rate the stress test is positive. That means, suppose you do a patient does a stress, he starts getting ST segment changes at a rate of 130. You must see to it that the beta blockade is such that during exercise, his heart rate is kept less than 120. So that is the importance of heart rate and stress test in stable angina. In ACS, we all know that higher the heart rate reduction associated with decrease in post-MI cardiac deaths. A lot of data for several years. In fact, many studies have shown that increased heart rate increases mortality and CV events. And a lot of ACS models now have actually included heart rate as a prognostic factor. Remember, for an anterior wall infarct, your sinus rate more than 90, especially more than 100 or less than 50 is a risk marker for increased mortality. And there are two recent events. There are two recent evidences. Number one, they looked at admission heart rate in patients with acute coronary syndrome. Patients coming with an acute MI, and they looked at the admission heart rate. And they found that admission heart rate was independent and positively associated with the severity and complexity of coronary disease. That means if somebody had a higher heart rate on admission, his chances that he will have multiple blocks and complex anatomy on a coronary angio can be compared depending upon your admission heart rate. Similarly, there was a very good study which showed that discharge heart rate after a myocardial infarction with long-term model. That means suppose your discharge, you do an angioplasty or you thrombolize a patient or your patient comes late, is not thrombolized. If you find that at discharge, if the heart rate is more than 100 at discharge, it's an independent risk factor for patients with acute myocardial infarction. Now, going from stable angina to ACS to hypertension, simple hypertension. What is the correlation of hypertension and heart rate? Higher the baseline heart rate, more the chances of developing hypertension. In hypertension, more the heart rate, more the chance of proteinuria. And in hypertensive patients, higher the sinus rate, more chance of organ damage, that means target organ damage, that means left ventricular hypertrophy, higher and increased mortality in hypertensive patients. Now, if you see hypertension and heart rate, remember this increase in heart rate is associated with increase in the risk of hypertension, developing hypertension, number one. In those patients, if the heart rate is more than 80, and some articles more than 85, we have a 3 to 4 times higher risk of hypertension, and you can have adverse outcomes in hypertensive patients if you don't control the sinus rate. So, management of heart rate in hypertensive patients is crucial. Now, in general, remember, beta blockers all over the world, fell into disrepute in treatment of hypertension. But still, there's one important Indian study, the BEAT survey, which clearly showed that resting heart rate in Indian hypertensive patients is associated with high blood pressure. So that is why we have to be, at least in India, we now have a lot of young patients who come to us with hypertension. We must look at their sinus rate. Sinus rate at rest more than 85, and in some articles more than 90 at rest in a young hypertensive patients. You must see that you control your heart rate. Now this, in a young patient, may not necessarily be beta blockers. It can be lifestyle modification, loss of weight, and good endurance exercise. Good endurance exercise increases the vagal tone and decreases the sinus rate over a period of time. It doesn't happen, over one weekend that you go and sort of do an exercise and over weekend your heart rate starts decreasing. So good endurance exercise over a period of time really helps in decreasing. So this is about hypertension and heart rate. So in hypertensive patients, we must see that the sinus rate is less than 85 at rest. Heart rate and congestive heart failure. A few things about heart rate and chronic heart failure. High resting heart rate, again, high resting heart rate is associated with higher risk of mortality in ischemic patients, especially of heart failure. The cardiovascular death, remember, is increased by 14% for 10 mm. If your sinus rate increases by 10 mm, you'll have an increased mortality by up to 14%. And that is why in congestive heart failure, in chronic heart failure, the resting elevated heart rate has to be avoided, and that is important. Now, I'll show you a few evidences of rate and rhythm in heart failure. Simple. The first is, recent evidence showed that patients with reduced ejection fraction at the highest heart rate, followed by heart failure with preserved EF, and then followed by mid-range ejection fractions. So people with the lowest EF did the worst, followed by preserved EF, and followed by the mid-range. So you must be careful that, remember, with reduced EF, you cannot have a suboptimal heart rate control. It's important. And a few evidences in patients with heart failure. Number one, sinus tachycardia in congestive heart failure is a marker of poor prognosis. And there's a very, very interesting study several years ago, which clearly showed that for all patients in heart failure, if they had a basal heart rate of more than 90, and the Jessica trial, they gave amiodarone and beta blockers to the patient. And if your heart rate decreased below 90, only then your mortality improved. If your heart rate did not decrease below 90, there was no change in mortality despite amiodarone in 100% of patients and beta blocker, I think, in 25-30% of patients. So is the importance of sinus rate in congestive heart failure. The second rhythm you must know in congestive heart failure is atrial fibrillation. Patients with preserved EF with diastolic heart failure, if they develop atrial fibrillation, that is bad. Patients with moderate congestive heart failure, NYJ class 2 to 3, there the atrial kick is important. There, if they develop atrial fibrillation, it has poor prognosis. In the end stage, and when the patient is in end-stage heart failure, atrial fibrillation does not make a difference in mortality because by itself, LV ejection fraction will increase their mortality. Now, in a patient with heart failure, what will you see on an Holter? If there is silent VT, yes. Non-sustained VT, yes, because I would like to think of a ICD. More important is ventricular ectopic burden. Ventricular ectopic burden in 24 hours, more than 20% in heart failure patients is sinister. That means there is a criteria which says that some patients should have an ICD, or at least you must try to suppress the ectopics, especially when the burden is more. So this is the rhythm you must know in heart failure patients. Similar in heart failure patients, heart rate variability, that means decreased heart rate variability is a risk factor in congestive heart failure and AMI. And of course, beta blockers are the best drugs to improve the heart rate variability. Now, just a word about circadian variability. Overall, in general, you must know that heart rate decreases at rest, especially at night. So at night, during sleep, especially in a diabetic patient, if you find that the heart rate doesn't decrease, it is not good. It shows poor prognosis. Overall, in the early morning hours between 3:30 and 5:30, more arrhythmias, more incidence of BP surges, more incidence of AMI, more incidence of stroke, and poor response to thrombolysis in the early hours of the morning. So circadian variability is for different parameters. One of them is heart rate, and that is important. So if you have a heart rate, there's no dip in the heart rate during sleep, especially in diabetics with neuropathy, in autonomic neuropathy, it is not good. Now, the next subset which I would like to discuss is a common subset is rheumatic heart disease. Now here, atrial fibrillation, we are looking at a ventricular rate which is fast. So if you have atrial fibrillation with fast ventricular rate in a rheumatic heart disease patient, what does it do? Remember, if somebody has a moderate lesion, that means somebody has an area of 1.5 and say 2/4 MR, then atrial fibrillation with a fast ventricular rate makes them symptomatic. They can go into pulmonary edema. And that is why those patients whom otherwise I would have conserved if I had looked at the heart rate control, will require an intervention, number one. Number two, fast ventricular rate in atrial fibrillation for a long time will cause LV dysfunction, that is tachycardiomyopathy, which we will discuss later. Why this is important? If you already develop a tachycardiomyopathy in a patient who you have to replace the valve, remember, patients remain symptomatic despite valve replacement. And last important point in rheumatic heart disease is higher the heart rate with atrial fibrillation patients, more the chances of thrombus and embolization. So these are the few important clinical points you must know that in rheumatic heart disease patients, my heart rate, my ventricular rate in patients with atrial fibrillation must be controlled. For that, what should I do? For those with normal LV in rheumatic heart disease patients, I would like to give a combination of lenoxin and diltiazem or lenoxin and verapamil. In general, both there were very good studies several decades ago which compared both these drugs, and it showed that lenoxin plus diltiazem and verapamil are equal to control rate at rest, but diltiazem is better than verapamil with digoxin to control ventricular rate during exercise. So I would give a combination of lenoxin with a good dose of diltiazem, and if that doesn't decrease the rate, then I would give a small dose of beta blockers. In patients with LV dysfunction, it's difficult. You can't give diltiazem or verapamil. Then you have to give lenoxin plus a small dose of amiodarone and I add a small dose of beta blockers. However, many times this does not work, and if your patient starts coming with repeated admissions because of fast ventricular rate in atrial fibrillation, then we do what is AV nodal ablation and put a pacemaker so that the patient's heart rate can never exceed 70, what we set on the pacemakers. So these are the few issues of controlling ventricular rate and what high ventricular rate in atrial fibrillation in rheumatic heart disease does to patients. A few other subsets are basically if you diabetic cardiac autonomic neuropathy. That means here what is a long-standing diabetic patient, what happens is the resting heart rates are higher, number one. Initially the heart rate increases, then it may decrease because it's a play between sympathetic and parasympathetic systems in a neuropathy. So it depends which is predominant. Initially it may be parasympathetic or sympathetic, and finally in the last stage they come to what is called a fixed heart rate. That means you see a long-standing diabetic with autonomic neuropathy, you will find his heart rate is always between 95 and 100. It doesn't decrease much, doesn't increase much. And the response to exercise may not be significant because it's just a balance, perfect balance, where the rate doesn't decrease, just is between 95 and 100. And that is basically bad news for a diabetic patient. Why is this important? Because in diabetic patients, if you have CAL, neuropathy, increased cardiovascular events, increased chance of sudden death, increased mortality of AMI, and increased chances of stroke. So these are the few implications in your long-standing diabetic patients. Look at their heart rates. If they are sinus arteries, of course, it should be not more than 90 or 85. It's the resting heart rate. But even if beyond that, if you find that it's a fixed heart rate, 95 to 100, be careful. They possibly are developing autonomic neuropathy. Finally, three important points about tachycardia-related syndromes. That means first is what is called inappropriate sinus tachycardia. The second is postural orthostatic tachycardia syndrome or POTS. And third, of course, is cardiomyopathy. Simple, but I'm just going to mention a few. What is inappropriate sinus tachycardia? That means the patient has an elevated resting heart rate more than 90 to 110 at rest. As I told you, it should be less than 85. More important is the inflated or aggravated response to any physical or emotional stress. That means the patient is taken on a treadmill. Within 30 seconds, the rate suddenly goes to 160. So that is important definition, one of the important pointers in the definition of inappropriate sinus tachycardia. Seen in younger people, more predominant in females, And because of this, patients have multiple symptoms. They have palpitations, they have fatigue, they have neurotic symptoms, several things. So what do? There are 3 drugs which have been tried for inappropriate sinus tachycardia. There are ablation procedures, but here, out of the 3, evaporatin is better. Beta blockers, you have to be careful because beta blockers, low-dose beta blockers, evaporatin or non-hydropyridine calcium channel blockers are the different drugs which you can keep for inappropriate sinus tachycardia. Now, here you have to assure the patient this is not life-threatening, but it makes them symptomatic. So this is a tachycardia sort of syndrome where the patient's sinus rate is far more than the activity he's doing, and that is what makes him symptomatic. So this is the first syndrome, tachycardia related syndrome, inappropriate sinus tachycardia. The next is POTS. Okay, so this is because of ANS fails. That means autonomic nervous system fails to compensate for a postural change. That means when a patient suddenly gets up or stands, his rate suddenly increases from 50 to by 5 to 30 beats per minute. This is called postural orthostatic tachycardia syndrome. That means any orthostatic stress will cause them. They have multiple symptoms. They get up, when they suddenly get up for a few minutes, they have tachycardias, they have palpitations, they have a lot of what is called brain fogging. You know, they don't know what to do. So they are really symptomatic. Sometimes this happens more often after meals because in meals, all the blood supply is diverted to the gut. So you should have small meals. Exercise programs helps, and they have tried midodrine and alpha stimulant, very low dose beta blockers, because if you give higher beta blockers, they become hypotensive. Pyridostigmine can be tried because it increases acetylcholine and therefore it increases the vagal response in this patient. And of course, evaporatin has been tried. So this is the second tachycardia-related syndrome where the patient becomes symptomatic because the postural change from lying down to upright position cannot be compensated by the autonomic nervous system. And you must carefully take the history, because otherwise you will miss it and people go running around to psychiatrists, in fact, because their symptoms, and it is labeled as a panic anxiety syndrome rather than POTS. This is an important thing you must know about heart rate. The third, of course, important tachycardia related syndrome is tachycardiomyopathy. That means persistent high ventricular rate, okay, because of any cause. It's usually an incessant atrial tachycardia, or as I mentioned, rheumatic heart disease patients, atrial fibrillation with a very fast ventricular rate for a long time causes LV dysfunction. And the important point is, you must know that this is a reversible process. If my tachycardia is controlled, then I can reverse the LV function or LV dysfunction. That's important. Now here, so what is the corollary? Any young patient who has LV systolic dysfunction, and if you find that his pulse rate is always between 130 and 120 and 130 or 110 and 130 all the time, then you must suspect tachycardiomyopathy. Why is this? Because sometimes these patients are labeled as viral myocarditis and given a lot of drugs, and they will never improve unless you ablate the atrial tachycardia. So that is why this particular tachycardiomyopathy concept is extremely important. Any young patient with LV dysfunction, look at his 24-hour Holter and look at his heart rate profile. If you overall find persistently the patient is in the rate of 120, 130, there is a good chance that he may have a tachycardiomyopathy. And the importance is that they are amenable to radiofrequency ablation depending upon the tachycardia they have, and the LV systolic dysfunction is reversible. So these are the 3 important syndromes you must know about heart rate and tachycardia and heart rate, and what they can cause, different symptoms, including LV systolic dysfunction. Finally, what is optimal heart rate? Suppose somebody asks me, in a normal person, what is physiologic heart rate? Number 1, Before that, a normal population, 75 to 85 is normal heart rate. 85 is the upper, higher limit of normal. Anything more than 85, you see all the studies, most of the studies are more than 80, 83, 85, and 90. So anything more than 85 consistently at rest is a risk factor. Now, the question asked, suppose a normal person has a a rate of more than 85, what do you do? Is it physiological or pathological? Now, in general, remember, in a normal person, the important thing to do, so what should you do? Should you intervene? Yes, most important is physiological. That means, as I mentioned, you must do good level of endurance exercises, because which actually stimulates the vagal tone. Higher the vagal tone, you will start reducing your sinus rate. But please remember, this takes a long time. It doesn't have happened over a few days or a few weeks. It takes months if the exercise is done consistently. Most of the patients or normal people, their consistency and the level of exercise is so pathetic that it can never affect the physiology of the heart rate. That is important, number one. In a normal person, if the heart rate at rest is 90, should I intervene with drugs? Should I give him beta blockers, evaporating or calcium channel blockers? The answer is no. Just to decrease the heart rate below 85 in a normal person without any disease, I would not do this. But I would certainly tell the normal person that he must do lifestyle modification, good level of endurance exercise, meditation, yogic exercises, so that overall his vagal tone improves. So for a normal person, a resting heart rate more than 85, you require lifestyle intervention, no drug intervention. So finally, the whole concept of this heart rate is, in what we have seen, that it affects all aspects of clinical syndromes which we have seen in our day-to-day clinical practice, right from mortality overall to ACS, to stable angina, to heart failure, to rheumatic heart disease, atrial fibrillation, fast ventricular rate, to diabetic patients having autonomic neuropathies, and of course, all heart-related tachycardia syndromes. So several aspects of clinical syndromes. Remember, perhaps it's the heart rate which is the missing link. We never think. We do all sophisticated tests. The first thing which we normally look at, the patient sleeps on a table, is look at his pulse, look at his pulses, peripheral pulses, and look at his heart rate. But now we used to never figure out that what does this really, the importance of heart rate was never known till of late, say perhaps 1 decade. People used to take it lightly. People used to take BP, everything else, but never look at the sinus heart rate at rest. And this should change. And that is the importance or the message of this lecture, that we must know that the importance of controlling heart rate in different clinical subsets is extremely important, because it does change mortality and it does change the whole prognosis of patients, right from ACS to hypertension to heart failure to a lot of syndromes which we have discussed. So in general, remember, slower the better, and see the lifespan of all these animals which I showed you earlier also. Higher the heart rate, the less you are going to live. Slower the heart rate, the more you are going to live. Of course, there are other factors, but this is an important factor, that slower is better. So in conclusion, ladies and gentlemen, this lecture was to make all of us aware of the potential importance of controlling heart rate in various clinical syndromes. Remember, its clinical implications, which I have mentioned, are extremely important in different subsets, and you must take it seriously. For example, you are treating a patient of heart failure, he comes to your OPD, heart rate is 90, not acceptable. So you should have a protocol for heart rate in different syndromes. So clinical implications in various subsets are important, and risk reduction by heart rate modulation is not a myth, it's a fact. And it's an important fact, and there's a lot of data over it. People have written books on heart rate. So now in 2022, heart rate is an important, simple parameter in different clinical syndromes, because we can reduce the risk of different events by just heart rate modulation by drugs. And of course, for those who are listening to this lecture, when they go home at rest, please feel your pulse. If you really find that your heart rate, resting heart rate is more than 85, this lecture is a wake-up call for good lifestyle modification. Thank you very much.
Thank you so much, Dr. Sathe, for this insightful awareness session for World Heart Rhythm Week. We hope our doctor community would definitely gain a lot out of this. Dear viewers, please drop in your queries and questions in the comment section below, and we would get back to you with the answers. Thank you so much for your patient hearing. And until we see you again, please take care and have a great evening ahead. Thank you so much.